Hi guys, good to see you once again. So with a lot of cricket fans coming up in the chat, I think RCB and a CSK match going on. I know that would be a very very difficult thing to miss, but still I hope that I would be able to motivate you to not do any sacrifices. Watching cricket for a while is gonna be always a pleasure. But yeah, with the Holi festival around the corner, a bit of lethargy on the weekend can come in because it's usually a long weekend. And because of that, what can happen is that can set up the study schedule a little off the track for maybe a few days. So that's a pretty long time to miss out. So with those words, I think we're good to go for today, and we are good to discuss a couple of important questions. So as far as today is concerned, my objective would be to expose you to a couple of questions from QBank 6.0. And most of these questions that I'll be discussing are a combination of one-liners as well as clinical ones, and you can make a switch also. There's a toggle in the app, and you can toggle between a one-liner versus a clinical-based question, and that's a welcome feature in a sense that especially if you are preparing for NEET PG, if that's your primary target, you can move on to one-liners. If you're preparing for NEET, then for the same topic, I mean, you can toggle to the clinical-based question. So very good evening to everybody. And Doc, you'll see a couple of differences. Doctor, somebody mentioned there. So okay. So let's see and check out whatever you are gonna say. I mean, differences are bound to be there, and let's look at what are gonna be the responses to these questions. I mean, then let's test out your reflexes. So we start with the very first one to today. Very good evening, Dr. Mishra, Angry Bird, Satya, Monica. As far as the updates in the videos are concerned, if you're watching 5.0 and you don't want to migrate to 6.0, that's perfectly fine. And what I'm going to do is all the updates I'll compile at a single place. So give me some time, and then I'll post a video of like all the updates at a single place, and that would make it less, a hassle for you. You don't need to watch then in case, I mean, that's optional. If some people love to watch the newer updates, and some people are like, no, I've gone through 5.0 and I'm having a visual memory, so it's perfectly fine. And yes, I'm getting straight away answers. Dr. Jain, Dr. Urvashi, everybody is talking about chronic renal failure in a patient, and we are very well aware of the fact that in any patient of CKD, I mean, there are bound to be electrolyte imbalances that can be present. Now, okay. So I am still getting B in the feed, and what you have to pick up is that CKD will always be associated with hyperkalemia, and hyperkalemia should be having presence of tall tented T waves. But I don't think so. Anywhere you are seeing tall tented T waves, I'm just zooming it in for those of you who are commenting. तो यार ये जो मार्किंग है ये T wave थोड़ी ना, ये तो R wave है. This that you can see is not a tall tented T wave, guys. This that you're marking is seen is the R wave. You can see there is a Q. Like I'll just do markings there, right? ये जो green से मैं mark किया ये Q wave है. Then what is going up is R, and then you can see a S wave. So this is definitely not a hyperkalemia. You have to read the question very carefully, guys. And for those of you commenting that okay, it's the same. No, guys, it's not the same. I mean, a CKD chap is on multiple medications. So, hota kya hai? I mean, what happens usually is that in patients who are having CKD, you could be putting them on diuretics also, no? And when you are going to be putting them on diuretics, then there could be possibility of hypokalemia also. So I want you to get sensitized to the fact that, okay, I mean, in a chronic kidney disease patient, there's bound to be hyperkalemia, but at the same time, thiazides could be given. And one of the most important thing that I am now getting, in the feed, because now guys are getting a hang of this. Ab dhyan se dekho, I mean, if I'm zooming it in, you can notice the presence of T wave inversion. And apart from T wave inversion, there is also a ST segment depression. अब ST segment depression कहाँ पे दिख रहा है तो मैं आपको दिखाता हूँ. जैसे कि you can see a ST segment depression at this particular case, or you can notice a T wave inversion which can be seen at multiple areas. So this, guys, is not a question related to hyperkalemia, but is rather a feature that would be seen with hypokalemia. In fact, in case you made an error for this particular question, what I want you to focus is especially on findings with respect to, let's start with lead number V5. I mean, suppose आप कहते हो कि sir, so many leads are given in the exam, and like where should I be looking? Then you can look at long lead 2, or you can look right at the lead right at the bottom. Select single lead only. If you select a single lead, then what you have to pick up in this question, and I'll do some markings here. So just give me a few seconds to highlight that. You can notice this is R, and then you can be noticing a presence of a T wave inversion. So considering that you can pick up a T wave inversion, this cannot be a possibility of a hyper. As I've explained, hyperkalemia में तो tall tender T waves होता है. So the highlight of this particular ECG is, and the correct answer for this one is option number A. And this is what they're always going to do in the exam, that though not always, yeah, the rabbit ear is the conduction defect that could be coming up. I mean, both hyper and hypokalemia will affect the conduction of the heart. So that is why that rabbit ear appearance can come, or a bundle branch appearance can be coming. So yeah, Divyansh, you were right for that. And another electrolyte imbalance that could be asked to use hypocalcemia. Here it is hypercalcemia, but that in CKD you could also be having is a hypocalcemia, which would be causing a QT prolongation. And apart from that, as I've already explained, in fact, I'll use a different color to highlight this. CKD will have hyperkalemia. That should be always having tall tender T waves, which is not the answer to this question anyway. As I've explained, plus there is bound to be ST segment elevation, so not present in this case. Plus मैं क्या कह रहा था, मैं ये कह रहा था कि भाई CKD के सवाल में another electrolyte imbalance can be that of hypocalcemia, and hypocalcemia is associated with QT prolongation as well. So a lot of questions that have come up in the recent exams will either give you a patient or heart failure or a CKD patient, and then he is going to ask you about electrolyte imbalances. Because whenever we are treating a heart failure patient with suppose AC inhibitors, there can be a possibility of a hyperkalemia, and especially a CKD patient on diuretics, there could be a hypokalemia as well. So Uttam, there are a lot of आप videos में check out कर लो ना, durations are changing and the updates are there from the latest edition of Harrison. So those differences, as I've said, I'll be posting in a separate video so that you don't have to scroll through each one of them separately. That is dependent on like you are a first time listener or whether you have already gone through it. If you're going to be sitting for this time's NEET PG exam, you are already having a visual memory of 5.0, then you do not need to switch to 6.0. But suppose you are going through the notes the very first time, तो फिर तो कोई दिक्कत ही नहीं है यार. You can go through the updates in the very first place. So I think we are started with the very first question for today, and let's move on to the second one for today, which I think would be a relatively easier one. So let's look at your responses for this one also. Hi, Dr. Gauri. Very good evening. This is a patient who's having blockage in his left circumflex artery, so he had to undergo a stenting. I mean, you were aware that patients who are diabetics might be having a requirement of a PTCA, that is percutaneous coronary intervention, and along with that, they might be having a requirement of a drug-eluting stent. So this person is already having established atherosclerotic cardiovascular disease, and this is one question that I've already highlighted multiple times. I'm doing it once again to emphasize this fact before you, that in every diabetic who's having a very high incidence of atherosclerotic cardiovascular disease, you need to start the patient on GLP-1 receptor agonists. I'm getting a mixed response in this one, guys. Pioglitazone is contraindicated. Pioglitazone तो heart disease में वर्सन करता है ना. The answer to the current question, which is on the screen, is not pioglitazone. Pioglitazone would be contraindicated in a setting that there is already increased cardiovascular mortality in these patients. Yes, Dilpreet Kaur, the first answer would be atherosclerotic cardiovascular disease, would be a GLP-1 receptor agonist, as I've highlighted multiple times in my discussions. That's a 2023 update that the person has to be started on semaglutide, and that's gonna reduce the CV mortality. In fact, there are two drugs which you have to be familiar with. That is one, semaglutide, and second is SGLT2 inhibitors. Though in this particular question, there was no mention of any SGLT2 inhibitors per se. SGLT2 inhibitors are more recommended in those patients who are having concomitant CKD. In fact, the update from 2023, which I would like to mention, is like this. In fact, if you go through the diabetes video, which is now up on the app for today, you will notice that I have basically spoken about the 2023 guidelines. And in that, what he's highlighted is specifically that in any diabetic, you have to first evaluate, is there a risk of atherosclerotic cardiovascular disease, or there is a concomitant presence of CKD, because diabetic nephropathy would be present. If there is atherosclerotic cardiovascular disease, he has recommended GLP-1 receptor agonist, or he has mentioned regarding usage of SGLT2 inhibitors. SGLT2 inhibitors are not given if the eGFR is less than 40, and especially for empagliflozin, it can be used up to eGFR of up to 20 ml. So the point is, we want to reduce the progression. And if only CKD is present, then SGLT2 inhibitor is the first line answer. So this is gonna be yes, Dr. Daisy, that is what I'm trying to say, that you will check out in the update that in the American Diabetic Association, they have first mentioned GLP-1 receptor agonist and then they mentioned SGLT2 inhibitor. Plus एक second problem है ना जो मैंने अभी आपको बताई कि SGLT2 inhibitors should not be given if the estimated GFR of a patient is less than 45. So suppose he gives you a cardiorenal syndrome, no, like the person is having heart disease and then is having a chronic kidney disease also, then you cannot be using SGLT2 inhibitor, and then GLP-1 receptor agonist would be preferred. I repeat that again, like he gives you a situation where a chap has ended up with a cardiorenal syndrome. What I mean by cardiorenal syndrome per se is that if the heart will not function properly, then the kidney will also be affected. So in those circumstances, if the estimated GFR is less, then we'll be more comfortable giving semaglutide to the patient. So hi Nelson, very good evening to you, and the correct answer for this one is option number A, as I've explained. I got linagliptin, sitagliptin. That's the answers for in case there is a concomitant renal failure. And let's move on to the next one for today, which is bread and butter for both NEET PG as well as INISAD and the FMG exam as well. In fact, they're gonna be spaced like month, May, then June, then July. I mean, that's how the papers are gonna be. So let's start with this 50-year-old female is admitted with a diagnosis of acute kidney injury. The pH of this patient is showing 7.3 value, that is acidosis. And there can be two reasons for acidosis. Either it can be respiratory or it can be a metabolic one. Now in this question, the PCO2 is 32. So I cannot call it a respiratory acidosis. It has to be a presence of metabolic acidosis. So the first thing is very clear that we have worked out the primary change of this person. And now what we will do is we will apply the modified Winters formula. And in modified Winters formula, what you will do is something like this, that you will have to add 50 into the value. I've done this exercise so many times earlier before you, so it's just a quick replication to re-emphasize the facts that you have to match the actual PCO2 of the MCQ, which is 32, with the expected PCO2 with the formula. Now the formula would be 10, that is the value of bicarbonate, plus 15. I'm not going into that traditional 1.5 into bicarbonate plus 8 plus minus 2. I mean, if you want to do that, I'm perfectly okay with it. But आपने करना क्या है इस सवाल में, you have to calculate the expected PCO2 of the patient and then match it with the actual PCO2. You can see that the actual PCO2 in this question is 32 millimeters of mercury. The expected is 25 millimeters of mercury, and both the values are not matching. Because both the values are not matching in this condition, you have to always in metabolic acidosis MCQ apply modified Winters formula. होता क्या है, जो भी बाइकार्बोनेट का वैल्यू दिया होगा उसमें आप 15 को जोड़ देना. Whatever mathematical value will come, you have to match it with the actual value. Because there is no matching in this case, that means that this is an example of a mixed disorder, and therefore the correct answer for this one would not be what a lot of guys are prompting. Some guys were smart to quickly pick this up, but in case you have not, then my suggestion would be that in 6.0 I have added a ABG3 lecture where I have mainly focused on mixed disorders also. The objective is कि यार compensation वाला तो workout कर ही रहे हैं. I mean, I know that the first two videos you guys are very good with. You know about uncompensated versus partially compensated concept. But now I want you guys to upgrade a bit and then learn about mixed disorders as well. The correct answer for this one, yes, Ishita, that is what I'm trying to explain in this case. And for every metabolic acidosis question, what you're supposed to do is apply this mathematical formula. If this formula is satisfied, like if you go through questions in the notes that you have for video ABG1, video ABG2, you will notice that this formula is being satisfied. So that is why we were saying partially compensated. और क्योंकि ये formula satisfy नहीं हो रहा है, इसका मतलब the person has not been able to compensate. You see, because he's having kidney injury. Because of this, his compensatory systems may not be working very efficiently, and as a result of it, or he could be having a second issue. Second issue could be like diaphragmatic weakness. So a guy with diaphragmatic weakness compensate नहीं कर सकता ना. Compensation processes to healthy individual में चलेंगे. If a guy is sick, he is not in a position to compensate. The correct answer for this one is option number C, guys. It's a mixed disorder. फिर से explain कर रहा हूँ यहाँ पर कि आपको हर metabolic acidosis के सवाल में आपने expected और actual PCO2 को मैच करना है. Simple one step addition है. Rocket science नहीं बनाना उसको, क्योंकि रॉकेट साइंस बना रहे हैं तो भाई हमें खुद ही नहीं पता है ना. सिंपल सा फंडा होना चाहिए. सो इट इज एज सिंपल एज दिस, दैट व्हाट यू हैव टू डू भाई इनफ तो देखो कुछ भी नहीं होता है। इनफ इज हैरिसन भी पढ़ लो वो भी इनफ नहीं होती, फिर भी पूरी हैरिसन पढ़ के जाओ फिर भी लोग नीट एसएस का एग्जाम नहीं निकाल पाते पूरी हैरिसन पढ़ के 2 बारी। तो ऐसा कुछ नहीं है, यू जस्ट हैव टू बी, व्हाट मैटर्स इज स्ट्राइक रेट, व्हाट मैटर्स इज अंडरस्टैंडिंग ऑफ द बेसिक कॉन्सेप्ट। सो यस जी अनलिमिटेड, यू परफेक्टली राइट, देयर इज 2 टाइप्स ऑफ एसिडोसिस इन दिस गाय, मेटाबॉलिक एंड रेस्पिरेटरी एसिडोसिस। उसका मैं रैशनल भी देता हूँ वो क्यों हो रहा है। If it is yes Tariska, you were spot on in that, but let me just give a rationale. Acute kidney injury patient is having metabolic acidosis, so he should be having a compensation, that is respiratory alkalosis, उसमें कोई दिक्कत नहीं है। The point is a lot of time concomitant medical illnesses could be present. Because of this concomitant medical illness, the body will not be able to do a adequate compensation, which is why 2 types of acidosis are present. जब आप इसको फर्स्ट टाइम सुनते हैं तो the query that I get from young doctors is कि सर आर यू जोकिंग, मतलब मजाक कर रहे हो सर, PCO2 32 आप कह रहे हो, रेस्पिरेटरी एसिडोसिस हो गया। हाँ जी, रेस्पिरेटरी एसिडोसिस ऑब्वियसली 45 के ऊपर होता है, मैं मानता हूँ इस बात को, बट इन दिस पर्टिकुलर केस आपने रिलेटिव सेंस में सोचना है, रिलेटिव सेंस में सोचना है कि भाई इन दिस पर्टिकुलर केस, यस एग्जैक्टली, देखो अभी भी आ गया, यू नो इमीडिएटली द कमेंट केम, सर रेस्पिरेटरी एसिडोसिस कैसे बोल रहे हो, उसमें तो PCO2 शुड बी मोर देन 45 मिलीमीटर मर्करी। भाई वो एग्रीड 100% बिल्कुल सही कह रहे हो, बट यहां पर आपको मैथमेटिकल टर्म्स में समझना है, द पेशेंट का डायफ्राम इज नॉट बीइंग एबल टू कॉम्पेंसेट, तो CO2 का जो वैल्यू है दैट इज हायर हायर देन व्हाट इट शुड हैव बीन। द बॉडी शुड हैव डन अ कॉम्पेंसेशन ऑफ PCO2 अप टू 25, पर वो कर ही नहीं पाई बिकॉज द डायफ्राम ऑफ द चैप वाज नॉट वर्किंग, एंड दैट इज व्हाई इन दिस पर्टिकुलर केस द PCO2 इज 32। तो मैथमेटिक्स पे मत जाओ यहाँ पर, राइट, it is this mathematical funda that has to be explained, and I'll say this once again, diaphragm is not being able to work properly. That is why the PCO2 is 32. It should have been 25. That is what body operates on perfect mathematics. Because the body is not being able to operate on that perfect mathematics, that is why we're saying a mixed disorder. The correct answer for this one is option number C, especially guys who are going to be sitting for NEET PG. I mean, this has to be, very, very clear and spot on for you guys. So I think we are sorted for the current question on the slide, and let's look at the next one. Thank God I was able to explain, because in a live session usually you tend to be more focused about facts than the concept, but if I have been able to, then yeah, I really appreciate that. Crazy doctor, I love to, I mean, it's always there. A person would be more comfortable talking mother tongue than talking in any other language, alien language. But unfortunately, medical science is like that कि हमारा पेपर, बिल्कुल हार्डकोर इंग्लिश होती है, वर्ड्स लाइक रंबलिंग साउंड, अब पता नहीं होता यार रंबलिंग क्या होता है, राइट, लाइक लुक एट द इंग्लिश देयर। सो Dishant, algorithm for a metabolic disorder. pH is, Dishant, that's I think clear there. I've explained, no? pH is less, acidosis and bicarbonate भी कम है ना, वो तो डायरेक्शन ऑफ एरोज ही तो देखने होते हैं। वो रोम वोम में मत करना निमोनिक वोमोनिक से कि उससे निकालने में बैठ रहे भाई, लॉजिक से करना है, ट्राई टू वर्क इट ऑन द बेसिस ऑफ लॉजिक। तो रोम निमोनिक काम नहीं करेगा यहाँ पे, लॉजिक पीएच कम है तो या तो PCO2 बड़ा होना चाहिए या बाइकार्बोनेट कम होना चाहिए, तो बाइकार्बोनेट लेस था तो मेटाबॉलिक एसिडोसिस हो गया। Chalo ji, fine. I'm getting a little funny answers there. 30-year-old man with exertional dyspnea and fatigue, and the auscultation reveals a soft, low-pitched rumbling sound after a second heart sound in this particular chap. Which of the following lesions will be present? तो मुझे A मिला। aortic stenosis तो बच्चों में होता है या adults में होता है? I mean, why A is unlikely an answer, because aortic stenosis, one will be having a ejection systolic murmur. Apart from ejection systolic murmur, I mean, valvular aortic stenosis कब मिलता है? So either it will be seen in a child or it will be seen in a geriatric population. It is usually seen after 65 years of age. So option number A is very, very unlikely. If it is gonna be aortic regurgitation, then he should mention about a early diastolic murmur, right? He should mention about a early diastolic murmur. I know I'm getting all kind of answers there. Hypertrophic cardiomyopathy is also ejection systolic murmur. So you have to rule out option A and option number D कि भाई उसमें ejection systolic murmur होता है, और यहाँ पे तो उसने after S2 बोला हुआ है. See, he's saying after S2, that means he's telling you about a diastolic sound in this guy. He's talking about a diastolic murmur in this particular case. So answer cannot be option number A versus option number D. Yes, guys, quick voting. I'm getting G Unlimited mentioning B. Then a couple of guys, और देखो, okay, very less number of people have answered the correct answer for this one. So मैं आपको ना, चलो अब आना शुरू हो गया, धीरे धीरे आंसर आना शुरू हो गया है. So let me just explain this line diagram to you. इस लाइन डायग्राम को ध्यान से देखना. What is happening is that there is a mitral regurgitation in the patient which is causing leakage of blood from the left ventricle to left atria because LV pressure is more than the left atrial pressure. This is gonna cause a loud, harsh pan-systolic murmur. So first I'm showing a pan-systolic murmur of mitral regurgitation. अब सुनते रहना. In a person who's having mitral regurgitation, all the blood जो ऊपर जाएगा LV से LM में उसको वापस भी तो आना है. जब वो ब्लड वापस आएगा तो इट विल मिक्स विद वेनस रिटर्न. यू कैन सी द ब्लैक इज गोना बी द वेनस रिटर्न दैट इज कमिंग फ्रॉम द लंग्स. यू कैन ऑल्सो नोटिस यहाँ पे बिकॉज ब्लड इज लीकिंग आई हैव शोन अ डायलेशन ऑफ द लेफ्ट एट्रिया. But ultimately, all the extra blood in the left atria will come back into the left ventricle during the phase of diastole, and during the phase of diastole, therefore, it will be producing a low pitch diastolic rumble, and this low pitch diastolic rumble is what I've tried to explain subsequently to you. So guys, the message is कि mitral regurgitation के patient में pan systolic murmur होता है, वो तो है, लेकिन साथ में ये भी तो समझना है, और ये मैंने रूटीन मेन वीडियो में समझाया हुआ है कि भाई ब्लड वापस भी तो आएगा. ऑल दैट ब्लड आगे जगह ही नहीं है, इट विल कॉन्ट्रीब्यूट टू पल्मरी एडिमा, बट देन वो सारा ब्लड वापस भी तो आएगा. तो दैट इज प्रोड्यूसिंग दैट डायस्टोलिक रंबल दैट इज प्रेजेंट आफ्टर S2. डायस्टोलिक रंबल होता है डायस्टोलिक बर्बर. सो द आंसर फॉर दिस वन इज mitral regurgitation. और आप देख रहे हो यहाँ पे दैट देयर वुड बी a left atrial enlargement and there would be a eccentric hypertrophy of the left ventricle in a case of chronic mitral regurgitation. Acute mitral regurgitation में तो LVF होता है, but there would be a eccentric hypertrophy that will develop. वो eccentric hypertrophy क्यों होती है? तो उसका कारण ये होता है कि all the blood that is going up from LV to LA also has to come back also, no? So this is a question. Yeah, doctor, why not aortic regurgitation? I'm coming to that. Aortic regurgitation produces a high pitched. Aortic regurgitation produces a high pitched early diastolic murmur, which I'll now mention before you. अगर वो aortic regurgitation होता, the murmur will die down like this. That is the early diastolic murmur that we see in patients of AR that are shown in current blue before you. So, I mean, considering the fact that he does not mention that very classical high-pitched murmur, that is why he's talking about this manifestation. Yeah, Dishit Patel, something like a tumor plug sound, but different from a tumor plug sound in a sense that tumor plug sound में तो tumor will go and impact the mitral valve. एरिक यहाँ पे कंसेप्ट सिर्फ इतना समझो कि हाई प्रेशर चैम्बर से लो प्रेशर चैम्बर में ब्लड गया एंड देन दैट ब्लड हैज टू कम बैक ऑल्सो ना. तो जब वो ब्लड वापस आएगा तो उसकी जो आवाज आती है दैट इज द वन दैट इज गोना बी सीन विद रिस्पेक्ट टू रेडिएशन. मतलब वो आवाज ज्यादा इधर एक्सिला में भी स्टेथोस्कोप रखोगे तो आवाज सुनाई देगी. दैट्स अ फीचर ऑफ mitral regurgitation का मर्मर ना, रेडिएशन टू एक्सिला. मतलब नॉर्मली तो मर्मर अपेक्स में सुनाई देता है, बट अगर आप एक्सिला में रख रहे हो वहां पे भी आवाज जा रही है. दैट इज बिकॉज जब ब्लड लीक करेगा तो इस ब्लड लीक करने की जो आवाज है वो रेडिएट करती है. जब द when the blood is gonna hit the wall of the heart, ये अब यहाँ पे we are talking about physics. When the blood is gonna cause leakage, there would be radiation of sound. आवाज जो है वो ज्यादा कहाँ पे सुनाई देती है? जैसे mitral stenosis का murmur is better heard अगर आप पेशेंट को लेफ्ट साइड पे टर्न करते हो, जबकि MR का murmur is better heard अगर वो एक्सिला पे जाती है. That's because pure physics की ब्लड का लीकेज हो रहा है. But the minimum information that I want you to understand is option number C. And yes, Devanshi, that is the point, Dr. Divyan Saini. That is what I'm trying to say. The moment you read this word, na, low pitch rumbling sound, तो माइंड में आता है mitral stenosis है ही नहीं ऑप्शन में. Traditionally speaking, a low pitch rumbling sound after S2 is a diastolic murmur that is heard in mitral stenosis. और सवाल ही यही है कि द सवाल इज दैट देयर इज नो mitral stenosis इन द ऑप्शंस. तो वही तो टेस्ट है ना यार, वही तो ट्विस्ट है ऑप्शन में कि भाई वो हमारा दिमाग एक स्टेप आगे लेके जा रहा है. देखो व्हेन यू सिट इन द एग्जाम, नो, द एग्जामिनर वुड ऑलवेज एक्सपेक्ट कि भाई यू कैन गो बियॉन्ड अ पैन सिस्टोलिक मर्मर. मतलब पीएसएम तो मतलब मस्ट नो है कि भाई पहला अंडरस्टैंडिंग इज दैट यू हैव टू अंडरस्टैंड दैट द ब्लड इज लीकिंग फ्रॉम अ हाई प्रेशर चैम्बर टू अ लो प्रेशर चैम्बर. But that extra blood, yes, Kirti, listen to this. Once this extra blood is going in the LA, it has to come back. This blood will be added with the arrow in black. Arrow in black is the venous return, and the green is the blood that went from LV to LA during systole. The first diagram is of systole. So that was producing a harsh ejection systolic murmur. And then during the phase of diastole in the second diagram is what you can see, that a rumbling sound that has been created. So I think that now it is sorted, and the correct answer for this one is option number C. So work it out, guys, work it out. In the exam, there is always gonna be, in MS, absolutely nishchit, there is a loud pitch opening snap which is present, which is not given in this case. So considering there is no mention of opening snap, again, mitral stenosis would be unlikely as an answer. So we'll move on to the easier ones also. Let's look at this one and let's check out your responses now. This is about a 50-year-old lady with rheumatoid arthritis. She has come to your hospital with headache, vomiting, and weakness. And she's passing a dark color urine for past 3 days. The painkiller combination is very interesting. Phenacetin, which is present along with aspirin, and there's a BP that's elevated. That's understandable because see, there is the painkillers causing damage to the kidney, as we can understand from the options. So every time there's damage to the kidney, a high renin state would come, and that high renin state will explain the presence of hypertension. And there is a pallor also. The reason for that pallor can be that erythropoietin production from the kidney can be hampered if the kidney is affected. And let's look at the quick votings. I am getting varied answers. Yep. I'm getting a B. I'm getting a C. So, guys, listen to this carefully. If you're talking about B and if you're talking about option number C, then should there be no mention of any anuria or oliguria in the question? Read the question once again. Is this a question of NSAID induced acute tubular injury or acute kidney injury? I mean, option B and C are not the answers to this question. That is, this QBank is all about that we want you to think with a rationale. Guys, NSAID induced acute kidney injury will cause anuria or oliguria, will cause a progressive rise of serum creatinine. There is no mention of the same. Anemia of chronic disease. That is not a diagnosis. That is just describing what is the type of anemia. The question is not saying what is the type of anemia. Why person is taking, I highlighted this, person is taking phenacetin. Phenacetin is a cause of analgesic nephropathy, and analgesic nephropathy is not a cause of acute kidney injury. It is a cause of chronic kidney injury. Analgesic nephropathy, when you read the data, analgesic, ye painkiller phenacetin has been banned. The questions still come in the books because this drug contributes to papillary damage. It causes analgesic nephropathy and it causes a CKD in a patient. The correct answer for this one is option number A. And dark color urine though, sir, can be present in anybody. I mean, if a person is, not drinking sufficient amount of water, even then dark color urine can be present. If a person is working, if went out to Dubai on a holiday, the temperatures in Dubai in open without air conditioning can be 47, 48 degrees Celsius, even higher. So even that heat exposure, or like in India, in the month of May and June, जब लू होता है, then temperature can go so high that person can develop a dark color urine. So dark color urine is not a feature of renal failure. That was just a, तभी तो बोल रहे हैं cut the noise. भाई MCQ में, if it's a one liner, two liner, some words are just to distract you. वो वर्ड्स को ही तो आपने हटाना है, that the words have to be picked up by you. It is keywords in the question. Phenacetin was the first thing that you have to pick up because that's not traditional painkiller that we use. So the correct answer for this one is option number A. That is going to be chronic kidney disease in a patient. If it is going to be Bombay or Calcutta, option number B and C, there has to be anuria, there has to be oliguria, there has to be a progressive, rise of serum creatinine, 1.5 times elevation, then doubling, then tripling as we study. So there is no description that is given for serum creatinine values or elevation with respect to blood urine nitrogen. So, yep, guys, the correct answer for this one is option number A. And okay, so anuria not in CKD. No, Ishita, we don't get anuria is a feature that would be encountered in ESRD, right? I mean, if the estimated GFR is very, very low, then we can have a anuria. That's okay. I mean, anuria per se is not a feature of CKD. It's oliguria, right? Anuria would imply that there is an end-stage renal disease. Cola color urine नहीं लिखा है डॉक्टर साहब. There is no mention of any cola color urine in the question. Anuj, read the question again. It's a dark color urine. As I said, a dark color urine can be passed by anybody who's not even consumed water. The question is not talking about cola color urine. Why not D? That is not a diagnosis. That is a manifestation. Chronic kidney disease causes decreased erythropoietin and causes normocytic normochromic anemia. So anemia of chronic disease is not a diagnosis. It is a manifestation of chronic kidney disease. The question is asking us कि भाई क्यों हो रहा है? मर ही जाएगा मेरे पास में, तो मैं से ये नहीं बोलूंगा ना यार कि तेरा किडनी छोड़ दे, तेरे को अनीमिया है, तेरा एरिथ्रोपोइटिन के इंजेक्शन लगाएंगे तेरे को. right? I have to say कि भाई kidney खराब हो गया, that is why there is anemia. Vice versa नहीं है ना, anemia is not causing renal failure. It is कि भाई आपका kidney affected हुआ, that is why we are giving you erythropoietin injections. So we are sorted for this one, guys. The answer is option number A, and let's move on to the next one. Yep. Objective is to keep some tricky questions there, and couple of them are gonna be easy. So hi Prajwal, good to hear from you. Management of this particular case, doc, we'll have to calculate the estimated GFR and then evaluate the grade of CKD. And based on the grade of CKD, we will manage. If it is grade 1 to grade 3, we'll do medical management. If it is grade 4, then we'll place for a renal replacement therapy. We'll obviously have to stop painkillers in the patient, but then the management of this particular question, management of CKD depends on the level of estimated GFR. So read about the grades of CKD and you guys are going to be more comfortable solving up these questions. And let's look at the next one. Which of the following will contribute to development of hyperkalemic acidosis? So yes, guys, after a previous one, which was slightly, I would say, you have to run a bit of logic. This, I think, would be a easier one. So yes, waiting for you guys. I'm getting A, I'm getting B in the feed, and I'm still waiting for the remaining guys. Come on, hit the comment button. ओके, तो अब सारे ऑप्शन आ ही जा रहे हैं. ए भी हो गया, सी भी, डी भी आ गया. ओके, सो दिस इज गोना बी फन, राइट? डायरिया में क्या होता है? डायरिया causes urinary loss of diarrhea causes loss of potassium in the stool, so there is a hypokalemia. And more importantly, diarrhea will cause circulatory failure, it will cause shock, so that will explain hypokalemic metabolic acidosis. फिर से बोल रहा हूँ, why diarrhea is not the answer for this question, because diarrhea will not contribute to hyperkalemia, it will contribute to hypokalemia. Whether it is cholera or any other case of diarrhea, we get potassium being lesser. That is why muscle cramps would set up, and because of the circulatory failure that would come up, the circulatory failure will explain the acidosis. So answer cannot be A. I got B as an answer. कौन syndrome तो बहुत बार पढ़ा है यार मैंने. कौन syndrome में एल्डोस्टेरोन ज्यादा होता है ना, ये डायग्राम मैं बना के, है ना, मुझे तो लगता है कि मतलब बहुत बार ड्रॉ किया. Aldosterone will cause salt and water to come back, that is okay, but at the same time there is gonna be a urinary loss of potassium and hydrogen. तो मुझे फिर से बताते हुए भी लग रहा है यार, ये तो मैंने बताया हुआ है, that there is a urinary loss of potassium and hydrogen, and therefore in option number B, what's gonna happen is that there would be a hypokalemic alkalosis. If you are an FMG student, guys, ये वाला जो क्वेश्चन है, ये तो ब्रेड एंड बटर है आपके लिए. मतलब नीट पीजी वालों के लिए तो आई मीन दोज गाइज विल सॉल्व इट एंड मूव ऑन टू द नेक्स्ट वन. दे सेव टाइम ऑन दिस क्वेश्चन. बट जो भी ऑप्शंस मैं बोल रहा हूँ ना, दीज आर लाइक क्वेश्चंस विच आर फ्रिक्वेंटली आस्क्ड इन एफएमजी एग्जाम ऑल्सो. सो इसको छोड़ना ही नहीं है. मतलब they'll always put up these questions. तो A और B तो बनता नहीं है. और अगर डायबिटिक पेशेंट को वॉमिटिंग हो रहा है तो वॉमिटिंग अगेन कॉन्ट्रीब्यूट्स टू एल्डोस्टेरोन इंक्रीज, एंड वॉमिटिंग ऑल्सो कॉन्ट्रीब्यूट्स टू अ hypokalemic alkalosis. I'll just put an arrow to say that even vomiting causes hyperaldosteronism, and therefore the correct answer is very easy, guys. All you have to pick up was कि भाई किडनी खराब हो गया. Every time there's a kidney that is खराब हो गया, there's gonna be inability to excrete hydrogen, there will be inability to excrete potassium, so there is a hyperkalemic acidosis in this case. The correct answer for this one is option number C, that is hemolytic uremic syndrome. भाई बहुत बार समझाया है कि मेटाबॉलिक एसिडोसिस के लिए निमोनिक होता है कल्ट. अब निमोनिक्स तो हर किसी को अच्छे लगते हैं, लेकिन पॉइंट ये है ना कि वो कल्ट अप्लाई कैसे करना है, वो भी तो जरूरी है ना. दैट कल्ट निमोनिक इज कीटोएसिडोसिस, यूरेमिया, लैक्टिक एसिडोसिस एंड टॉक्सिन. और उसको पता है कि वो यूरेमिया लिखेगा तो आप सॉल्व कर लोगे, तो यूरेमिया नहीं लिखा उसने कॉज लिख दिया. दैट इज गोना बी हाइपर हेमोलिटिक यूरेमिक सिंड्रोम विच इज कॉज्ड बाय E. coli O1. I mean, everybody is aware of that organism that produces Shiga toxin. This is the superbug that I'm talking about, E. coli O157H7, and this organism produces Shiga toxin, which causes complement mediated damage to the kidney. And once the kidney would shut up, there would be uremia, there would be inability to excrete potassium and hydrogen, which is why there's going to be shooting of potassium and hydrogen in the body. This question that I mentioned, diarrhea causes alkalosis. No, Dr. Vivan, diarrhea causes circulatory failure, right? It doesn't cause dehydration. It causes circulatory failure, underperfusion of tissues, and causes a metabolic acidosis. Yes, Gauri, typical and atypical HUS. Atypical HUS would be seen with drugs, that is drugs used for management of cancer. But when it comes to a typical hemolytic uremic syndrome, you're going to be having a diarrhea or a dysentery event, and following that, there would be a renal shutdown. So go through those questions and you would get a better idea regarding them. Okay, ji, moving on to the next one, we are having a patient with ascites and portal hypertension. He's having hepatic encephalopathy as well. So I thought I'll just decrease the pressure so that you guys can handle these questions as well. The previous, one preceding this one was a tricky one. Most guys got it wrong. So let's work it out. Addison causes hyperkalemia. Yep, absolutely, absolutely. Yo, yes. So I think this should not be causing a problem. He's just asking you regarding hepatic NSF. There is going to be asterixis in a patient. There's going to be flapping tremors that would be coming. And asterixis is a feature that's always seen in metabolic encephalopathy. So the standard causes that are asked to you would either be ammonia intoxication, that is hepatic encephalopathy, or he's going to talk about uremic encephalopathy, or he's going to talk about status asthmaticus, that is carbon dioxide narcosis. So, I mean, these are the usual reasons why you have development of asterixis in a patient. The correct answer for this one is option number D. There was a all except MCQ also on asterixis where answer would be thyrotoxicosis, because thyrotoxicosis would be causing fine tremors of the fingers. Yep. So we are sorted for this one. Let's move on to the next one. Alcohol would cause delirium tremens. It would be causing tremors, fine tremors in fingers due to sympathomimetic stimulation. So alcohol withdrawal, not alcohol, but alcohol withdrawal. And since you mentioned alcohol, I can also say कौन सा ट्रेमर होता है जो अल्कोहल पीने से कम हो जाता है? एक आदमी कह रहा है सर हाथ कांपते रहते हैं, अल्कोहल पीता हूँ तो ट्रेमर कम हो जाता है. Yes, guys. Waiting for your answers. Which tremors have you read जहाँ पे अल्कोहल पीने से ट्रेमर कम हो जाता है? अल्कोहल विड्रॉल की बात नहीं कर रहा. अल्कोहल विड्रॉल तो डेलिरियम ट्रेमर्स होता है, उसमें तो पेशेंट विल बी हैविंग रेज अटैक, बहुत गुस्सा कर रहा होगा, वायलेंट होगा, ही इज गोना बी लाइक क्रेजी चैप. तो व्हाट आई एम आस्किंग यू गाइस इज कि कौन सा ट्रेमर आप पढ़ते हो जिसको पीने से, अल्कोहल पीने से वो ट्रेमर कम हो जाता है? कहता है जब पीता हूँ तो बढ़िया है, एंड अदरवाइज लाइक दिस गाय इज हैविंग अ प्रॉब्लम. एग्जैक्टली रजत came up with that one, a very correct one. Mandar also came up with the correct one, that is ET, which is one of the commonest type of tremors that we see, that is essential tremors. So yep, I think Gauri also came up with the correct answer for this one, that essential tremors would be having would be decreasing. And this was anyway a simpler one. Yes. Which of the following is the indication for doing a hemodialysis in a patient? So साथ में commenting के साथ में, मतलब fun part के साथ में questions भी solve करते रहते हैं. The question says which of the following is an indication for doing hemodialysis in a patient? Yes. Okay, so I'll just give another few seconds and then we are sorted for this one. Absolutely, the absolute indication for doing a hemodialysis would be a uremic pericarditis. Uremic encephalopathy and uremic pericarditis is an indication for dialysis. वैसे करते क्यों है यार dialysis? I mean, you perfectly right. All others are complications that are gonna be seen. I mean, dialysis, dementia, metabolic acidosis, dialysis, disequilibrium. Option number A, option number B, and option number C are complications, and they are not an indication for doing a dialysis. The question is why is uremic pericarditis dangerous? And the reason why it is dangerous is because uremia or toxins can contribute to development of bleeding, and this bleeding can occur in the pericardial space. I repeat that once again. Uremia is a condition where there are toxins in the body, and the toxins will cause bleeding in the pericardial space, and this blood can accumulate to such a large amount that it can contribute to development of cardiac tamponade. Exactly, Vivan, you are spot on in explaining that there would be a platelet malfunction, there is going to be increased bleeding possibility, and as a result of it there can be development of cardiac tamponade. So because of the fact that there is going to be presence of hemopericardium in a CKD patient or acute kidney injury also, wherever there is a uremia, that is why we would be comfortable doing dialysis in this particular patient to get rid of the toxin, improve the platelet function, improve the coagulopathy component, and ensure that this guy lives. The learning point for you guys is, learning objective is that coagulopathy can be seen with liver failure as well as renal failure. I repeat that again. Coagulopathy liver failure में तो मिलती है. Coagulopathy is a feature which is going to be encountered in patients who are having liver failure because clotting factors will become less. लेकिन उसके साथ साथ पे even uremia, platelet malfunction contributes to increased risk of bleeding. किसी ने पूछा severe metabolic acidosis की कोई indication नहीं है. So it is, we can give soda bicarbonate to the patient. The formula for soda bicarbonate will be 0.5 into a weight into the target value, whatever is the value given in the question. That would be like 10, 15, whatever value gives you, and from that you have to, you know, subtract it from 24, and you will be getting the answers in you would be getting the answer for the dose of soda bicarbonate. Please understand that if it is not responding to soda bicarbonate, refractory metabolic acidosis is an indication. It is refractory metabolic acidosis, which is an indication. So I think Dr. Gautam, the answer is sorted for you. Dr. Dipender, I think that is sorted why the answer is not B, because you can treat it medically, guys. You can treat it with soda bicarbonate. If it will not respond to soda bicarbonate, that is when you are gonna be going ahead with dialysis in this particular case. So no, no, no. Severe metabolic acidosis is due to increased potassium. No, 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 no. Gauri says hemodialysis in hyperkalemia potassium is no. No, Gauri, we will go for medical management. Let me just write down the indications for dialysis, and that will make it very, very easy for you guys. That what are you supposed to remember? Indications for hemodialysis, number one would be uremic pericarditis. If in a multiple choice question, uremic pericarditis is also given and encephalopathy is also given, then you first have to answer uremic pericarditis. Why it's an absolute indication, why this is an absolute indication. I'm writing this AI, this is not artificial intelligence, it's an absolute indication, is because uremic encephalopathy, he can still survive for, you know, hours and days, but uremic pericarditis, if it translates into tamponade, the guy will die very, very soon. And then it's gonna be like, you know, the chap is having metabolic acidosis, which is refractory to medical therapy. So get that word right, that you have tried everything, you given soda bicarbonate to the chap, and still you are having a severe metabolic acidosis. It can cause damage to blood-brain barrier, it will worsen the encephalopathy component. That's when you're gonna treat. Similarly, if he says hypertension or hypertensive encephalopathy refractory to medical treatment, then is hyperkalemia रिफ्रैक्टरी टू मेडिकल ट्रीटमेंट. तो इनको वो पूछेगा क्यों नहीं, क्योंकि ये तो अब वैसे ही बता दोगे भाई, रिफ्रैक्टरी रिफ्रैक्टरी वर्ड लिखा हुआ है, रिफ्रैक्टरी टू ट्रीटमेंट मेटाबॉलिक एसिडोसिस, रिफ्रैक्टरी टू ट्रीटमेंट हाइपरटेंशन और हाइपरटेंसिव एन्सेफेलोपैथी. I mean, you given nicardipine, you are given labetalol, and still the BP is not getting controlled. There is a volume expansion that is occurring. It's causing, इतना BP बढ़ गया कि उससे पल्मोनरी एडीमा हो गया, तो भाई डायलिसिस कर लेंगे. Hyperkalemia refractory to treatment, so it's A, and it's the uremic encephalopathy and pericarditis are like the ones which should be remembered. And between pericarditis and encephalopathy, as I've highlighted, absolute indication is pericarditis. Why? Because it has risk of causing tamponade. Dialysis disequilibrium is a complication of hemodialysis. One session of hemodialysis should be 4 hours. First time जब dialysis करते हैं ना, वो 4 घंटे का नहीं करते. अगर फर्स्ट टाइम आपने किसी का, सपोज पेशेंट केम विद रीनल फेलियर और इज अ नोन केस ऑफ सीकेडी, यू आर प्लानिंग टू स्टार्टिंग ऑन डायलिसिस. इफ यू डू अग्रेसिव डायलिसिस फर्स्ट टाइम, द रैपिड फ्लूइड शिफ्ट will cause cerebral edema. Dialysis disequilibrium क्यों होता है? तो dialysis disequilibrium का जो reason है, though I've discussed this in one of my previous sessions also, that dialysis disequilibrium is basically a manifestation of aggressive hemodialysis. जैसे पहली बार पेशेंट डायलिसिस के लिए आया है और आपने उसका सीधा 4 घंटे डायलिसिस कर दिया, तो फ्लूइड शिफ्ट्स अक्रॉस द ब्रेन होंगे, उससे सेरिब्रल एडीमा हो जाता है. इसके मैनेजमेंट के लिए क्या देते हैं? तो मैनिटॉल देते हैं. दैट इज अ क्वेश्चन दैट नीट पीजी गाइज आर वेरी कंफर्टेबल विद, बिकॉज मैनिटॉल विल इंक्रीज द ऑस्मोलैरिटी ऑफ द प्लाज्मा एंड इट विल रिड्यूस द फ्लूइड शिफ्ट्स अक्रॉस द ब्रेन, एंड देयरफॉर द चांसेस ऑफ दिस गाय गोइंग इनटू सीजर्स वुड बी रिलेटिवली लेसर. एंड डायलिसिस डिमेंशिया क्यों होता है? तो आई थिंक somebody asked that is because of A beta 2, a myeloid deposition in the brain. I mean, it's not A beta for Alzheimer, it's A beta 2. And why it is beta 2 is because beta 2 microglobulin है ना, that is not excreted through the filter of the dialysis. जो dialysis machine का जो filter होता है, उसके holes इतने छोटे होंगे कि उससे beta 2 microglobulin excrete नहीं हो पाता. तो beta 2 microglobulin is normally excreted in the urine of a normal person. Now it's not going to be excreted, and it keeps on building up, building up, building up, and then gets deposited with respect to neurons and causes development of हाँ जी, वो ए बीटा 2 का रीजन बता रहा हूँ ना, दैट बीटा 2 माइक्रोग्लोबुलिन इज नॉट फिल्टर्ड अक्रॉस द डायलिसिस फिल्टर, एंड एज अ रिजल्ट ऑफ इट इट कीप्स ऑन एक्यूमुलेटिंग, और उससे फिर जो पेशेंट है ही कैन गो इनटू सब्सिक्वेंट डायलिसिस डिमेंशिया. सो मैसेज फाइनल इज गाइस, ए बी एंड सी वुड कंट्रीब्यूट टू कॉम्प्लिकेशंस, एंड डी इज एन एब्सोल्यूट इंडिकेशन फॉर डूइंग अ डायलिसिस. एंड वी कैन मूव ऑन टू आर में. नहीं यार, आर तो सेम ही रहता है यार, इट इज द मेन वीडियोज दैट विल चेंज ना. Chalo ji, let's move on to the next question for today. We have a 30-year-old man with occupational exposure to birds, and he's brought with complaints of progressively increasing dyspnea, with breathing trouble for almost last 1 year along with malaise. Serum precipitants to immunoglobulin G antibody is demonstrated. The CT scan shows ground glass opacities in upper lobes, and then we have a couple of possibilities here. So I'll just say that there is occupational exposure to birds in this particular case, and then he's also talking about breathing trouble. So this looks like an occupational lung disease only. And let me look at the options in this case. I'm getting A as an answer in this particular case, that is psittacosis. So psittacosis will cause symptoms for 1 year. I mean, psittacosis will cause symptoms for 1 year, and will acute infection, acute onset pneumonia contribute to IgG antibody? I mean, no, guys, absolutely not. I'll repeat that once again. First and foremost, there is exposure to birds, वो तो ठीक है. तो एक्सपोजर टू बर्ड्स को पढ़ के फर्स्ट लगता है यार सिटाकोसिस होगा, बट सिटाकोसिस वुड बी अ इंटरस्टिशियल निमोनिया which will present with cough. It would be a walking pneumonia, but there would be cough, there would be breathing trouble. It would be an illness of few days. एक साल से उसको दिक्कत हो रही है. So this is not gonna be like a psittacosis. This is gonna be a disease of occupational exposure. Plus, what is also giving you is this keyword serum precipitants. Serum precipitants word कहाँ लिखा होता है? Respiratory system में से एक ही बीमारी में लिखा होता है. Only one lung disease in respi will be having this word written, hypersensitivity pneumonitis. हाइपरसेंसिटिविटी न्यूमोनाइटिस के एग्जांपल्स होते हैं जैसे कि बागासोसिस, बाइसिनोसिस, और आगे बोलूँगा तो आंसर भी बन जाएगा, जो कि ऑब्वियसली यहाँ पर दिखाई दे रहा है. आई एम स्टिल गेटिंग आंसर्स लाइक सी वर्सेस डी. न्यूमोसिस्टिस जिरोवेसी निमोनिया में कोई बंदा 1 साल से बीमार होगा. और न्यूमोसिस्टिस जिरोवेसी का डायग्नोसिस कैसे होता है? या तो ब्रोंकोएल्वुलर लेवाज से करते हैं, या ब्रोंकोएल्वुलर लेवाज नहीं होता तो फिर स्पूटम से करते हैं. और उसमें हम क्या देख रहे होते हैं? तो वो ग्रीन वाली स्लाइड आपको बताई हुई गमूरी मिथामिन स्टेन पे. सो इज देयर एनी मेंशन ऑफ दिस पर्टिकुलर गाय हैविंग ब्रीदिंग ट्रबल फॉर फ्यू डेज, लाइक दिस गाय इज इम्यूनोकॉम्प्रोमाइज्ड? Like suppose this question said patient underwent kidney transplantation, now is having illness for 7 days, 10 days, 15 days, whatever. If the question mentioned a AIDS positive patient is having breathing trouble for let me say 1 week, and he's come to my hospital, X-ray is showing bilateral infiltrates, BAL is showing gomori methamin stain is showing cyst, फिर होता ना pneumocystis jirovecii. Guys, the answer to this is not option number C, pneumocystis jirovecii, because the data is not given. Histoplasmosis is like a cave explorer ना, ये तो बैट्स के एक्सपोजर से होता है, इसको तो केव्स डिजीज भी बोलते हैं. सो अगर हिस्टोप्लाज्मोसिस है, देन यू विल हैव टू डू अ ब्लड टेस्ट इन दिस पेशेंट फॉर हिस्टोप्लाज्मा एंटीजन, and you have to demonstrate the presence of histoplasma, right? You cannot be saying histoplasmosis on the basis of the history. This is hypersensitive pneumonitis. This is bird fancier's lung. The correct diagnosis of this particular case is option number B. इसका आंसर A क्यों नहीं है? Because A and C will be acute onset illness. A, B and C, A, C and D. Option A, option C and option D. Why they are not the answer is because they would be an acute onset illness. Our case is having illness for 1 year. Plus इनमें से किसी भी बीमारी में आपने क्या पढ़ा कि ग्राउंड ग्लास ओपेसिटीज होंगी. ग्राउंड ग्लास ओपेसिटी अगेन इज अ फीचर दैट इज टेलिंग यू कि ये एक लॉन्ग स्टैंडिंग लंग डिजीज है, एंड दैट लंग स्टैंडिंग लंग डिजीज वुड बी हाइपरसेंसिटिविटी न्यूमोनाइटिस. None of these, I mean, if it is psittacosis or girovesi or histoplasmosis, none of them in any class, whether medicine or in pathology or micro, wherever, you have so many resources available, उसमें ground glass opacities तो नहीं लिखा होता है. Ground glass opacities are again a feature that is seen with long standing lung disease. हाइपरसेंसिटिव न्यूमोनाइटिस फिर से पढ़ना, उसका डिजीज होते हैं बाइसिनोसिस, बैगासोसिस, बर्ड फैंसियर्स लंग. आई मीन दीज आर द टर्म्स विच आर यूज्ड टू डिस्क्राइब इट. तो बर्ड के जो फेदर्स होते हैं उनमें जो एंटीजन्स होते हैं, बर्ड के फीसिस में जो एंटीजन्स होते हैं, दे आर द वंस विच आर रिस्पॉन्सिबल फॉर द मैनिफेस्टेशंस इन दिस पर्टिकुलर केस. तो ओके. Yes, ABP has elevated serum precipitants. Great. That is again an allergic reaction to, precipitants का मतलब क्या होता है? It's not antibody, ना, it's immune complexes. Precipitin is not antibody. Serum precipitants basically means immune complexes which are demonstrated. So it's a chronic onset infection. IgG class of antibodies are present here. And the correct answer for this one would be option number B. and you have to work out the occupational exposure. Again, histoplasmosis is not routine, no, it has to be talking about somebody who's either having an occupational exposure to bats or is immunocompromised. I mean, that is how the disease manifestation would occur. Yes, yes, deadly venom. There is relation to pigeon feces. Pigeon feces would be mainly having cryptococcus, na? And they can cause cryptococcomas, and then they can cause cryptococcal meningitis as well. So pigeon feces, no. What is working out in this case is exposure to feathers, and yep, couple of antigens in feces of birds which could contribute to HP. Uh, 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 Lalit, my point against what you said is there should be a granuloma, agreed, but then lots of time, no, patient may not agreed for a biopsy, a transbronchial lung biopsy. So you'll have to base your diagnosis on basis of the radiological findings which are given in this case. So we are sorted with this one, and let's look at the next question on our screen. This talks about an alcoholic male. He's having abdominal pain, vomiting. Alcoholic question would always come up. One is delirium tremens always comes up. Second is the current scenario. This alcoholic has come to a hospital. He's puking after binge drinking, and you are noticing a couple of findings in this case. ग्राउंड ग्लास ओपेसिटीज इन न्यूमोसिस्टिस जिरोवेसी या पीसीपी की जगह पे न्यूमोसिस्टिस जिरोवेसी या डॉक वील कॉल देम बायलैटरल इन्फिल्ट्रेट्स rather than calling them ground glass opacities. Yep. Plus evidence, I mean, the diagnosis of PCP is mainly based on the lavage findings, or if you do not have a bronchial or a lavage, then it is increased alveolar arterial gradient. It is DLCO that is lesser. My suggestion to you guys, if you had problem solving this one, just go through the infections part in the main videos in medicine. It's hardly 3 hours. 2x पे सुनोगे तो 1.5 घंटा. बट आप, मुझे पता है आप इन्फेक्शंस बहुत अच्छे से आपको आते हैं, आपने माइक्रो में पढ़े हैं, बाकी सब्जेक्ट्स में पढ़े हैं. बट इफ़ यू इन्वेस्ट इन टू दोज 3 hours या 1.5 hours 2 hours ऑफ द इन्फेक्शन कॉम्पोनेंट दैट आई हैव डिस्कस, तो आपको थोड़ा ओरिएंटेशन बेटर हो जाएगा. क्योंकि बाकी सब्जेक्ट्स में दे विल जस्ट टेल यू दिस इज द मेन टेस्ट टू बी डन, लेकिन उसकी प्रेजेंटेशन क्या होगी, दैट इज व्हाट आई हैव ट्राइड टू एक्सप्लेन. ओके जी, सो लेट्स वर्क इट आउट गाइज. अल्कोहलिक बिंज ड्रिंकिंग, तो पहले तो मैं क्लियर कर दूं कि भाई बिंज ड्रिंकिंग के हर सवाल जो होता है दैट इज नॉट गोना बी अ प्रेजेंटेशन ऑफ बॉयरहैफ सिंड्रोम, है ना. तो और अगर ये मैलोरीवियर सिंड्रोम होता तो मैलोरीवियर सिंड्रोम में तो ब्लड का वॉमिटिंग होना चाहिए. अब तो यार सिली मिस्टेक्स कर रहे हो. मतलब आई नो कि होली आने वाली है. I know that there is a cricket match between Chennai Super Kings and RCB, and I mean Virat Kohli, Glenn Maxwell in a single team. I mean that's gonna be devastating firepower they have. But at the same time, you need to get your priorities right. Malarivius में तो blood का vomiting होता है, तो आंसर हो ही नहीं सकता, है ना. तो मुझे क्या क्या मिल रहा है यहाँ पे. ओके ओके, आई एम गेटिंग अ डी विच इज रूल्ड आउट, एंड नाउ गाइज आर गेटिंग इट. बॉयरहैफ सिंड्रोम, बॉयरहैफ सिंड्रोम जो होता है उसका डायग्नोसिस कैसे बनाते हैं. तो बॉयरहैफ सिंड्रोम का डायग्नोसिस इज बेस्ड ऑन द बेसिस ऑफ मैकुलर स्ट्राइड. मैकुलर स्ट्राइड में क्या क्या होना चाहिए. मैकुलर स्ट्राइड में देयर शुड बी प्रेजेंस ऑफ सबक्यूटेनियस एम्फाइसीमा. देयर इज नो मेंशन ऑफ सबक्यूटेनियस एम्फाइसीमा. Agreed that the person has presented with not chest pain, he has presented with abdominal pain. There is guarding, and I think everybody could pick it up, guys. There is a gas under the diaphragm. Gas under diaphragm मतलब क्या कि उसको पेप्टिक अल्सर डिजीज था. पेप्टिक अल्सर डिजीज क्या होता है, एच पाइलोरी से. और एच पाइलोरी क्या करता है, इट कॉजेज मोर एसिड प्रोडक्शन, इट कॉन्ट्रीब्यूट्स टू हाइपरगैस्ट्रेनीमिया. And the correct answer for this one is option number B. Absolutely, absolutely. It is gas under the diaphragm. That is the main evidence which has to be picked up. Mohan Raj, right side. Doc, that can be a gastric bubble also, right? That can be a gastric bubble also. But on the right hand side is significant. On the left hand side, it could be a gastric bubble also. But on the right hand side, it's perfectly fine. The correct answer for this one is Echinococcus granulosus will produce that water lily sign, no? The appearance of, I don't have an X-ray for water lily at the moment, so I'll include it in my subsequent discussions. But then, nope, this is not Echinococcus granulosus. This is not a water lily appearance, so can be ruled out. I can use a different pen to highlight that. This is gonna look like it's in the X-ray, so let me just put it on the other side. Echinococcus granulosus produces a water lily sign, so that is gonna be ruled out. Okay जी. And why this is not Boyraf syndrome, there is no medicine. और चलो, a lot of guys still mentioned there अल्कोहल इज अ डिस्ट्रैक्शन इन दिस केस डॉक्टर, अल्कोहल इज अ डिस्ट्रैक्शन, तभी तो बोल रहा हूँ कट द नॉइज वाली बात हो जाती है ना, दैट अल्कोहल इज अ डिस्ट्रैक्शन. इट इज अल्कोहल, अल्कोहलिक्स कैन बी हैविंग एनी काइंड ऑफ डिजीज, इट कुड बी इवन अ पॉसिबिलिटी ऑफ अ पेप्टिक अल्सर as well. Okay, so guys, that's what I'm trying to say. I got D in my feet again. That's not malarious. Malarious में blood का vomiting होगा, यहाँ पे blood का vomiting नहीं है. प्लस अगर ये बॉयरहैफ सिंड्रोम होता तो बॉयरहैफ सिंड्रोम में, चलो आप लोग कमेंट करो मुझे, बॉयरहैफ सिंड्रोम में न्यूमोपेरिटोनियम होगा या न्यूमोमीडियास्टिनम होगा, बिकॉज esophagus is gonna burst, right? So it's gonna contribute to air presence. And therefore there's going to be presence of a pneumomediastinum, and pneumomediastinum will cause gas above the diaphragm and not gas below the diaphragm. So sorry, first instincts are wrong. You have to practice, doctor, because in the actual exam it's merciless na. Actual exam is like that only na, that you don't get an opportunity second shot, you know, you get wasted, matlab 1 year is wasted, almost 1 year, you know. Even if you're sitting for FMG exam, आपको लगेगा यार 6 महीने बाद है, बट द पॉइंट इज वो पूरा साल देखो ना, इट्स नॉट दैट 6 months का पीरियड है. इफ समबडी इज नॉट क्लियरिंग इन जून, दैट मींस उसका पूरा एक साल खराब हो रहा है ना. सो वेदर इट्स FMG एग्जाम, नीट PG, 1 year, and 1 year is a very long time. I mean, just the hostel fees of yours, you know, wherever you are staying would add up, then food expenses, everything, and it's very difficult to get back on track for the second shot. So I mean, hats off to those who keep their wits and are able to pull themselves together and are able to do that. But my focus would be that whatever time that you have at your disposal at the moment, usko matlab give it the best shot that you got. And jitna tumme, you know, I keep on saying that again and again, so it will look very cliche, but then whatever capabilities you have, physical, mental, whatever, right, and a combination of the two, try to channelize them to focus on your studies, because that's what matters. Okay, chalo ji. Hammond-Krantz sign, डॉक्टर साहब, हो भी सकता है, नहीं भी हो सकता है, you know, because Hammond-Krantz sign is an auscultatory finding of pneumomediastinum, so you may not be able to hear it all the time. Okay, peptic ulcer causing stricture, yep, definitely on, will cause a stricture. Okay जी, yeah, absolutely, आप पढ़ो ना इस बार का FMG वाला देखो, नीट PG वाला देखो. I mean, that's crazy stuff that they ask there, so you have to be prepared. And not that I'm trying to scare you or something, it's natural. देखो mixed response होगा. कई क्वेश्चन तो इतने आसान होंगे कि आप बोलोगे ये तो मतलब आता ही है. जैसे फॉर एग्जाम्पल दिस क्वेश्चन ऑन द स्लाइड, हमें पढ़ते ही पता है यार इसमें क्या बड़ी बात है, right? And it will not cause any issue. And then there are gonna be ones where you'll have to, you know, sweat it out, and then there would be a couple of them where you will have to, you know, apply logic and come out to the right answer. So I have incorporated all the kind of possibilities there, so that I make you that mentally capable of handling the stress at that point of time. Because you see, the easiest thing for me would be to just come out with some strategy video, but वो इतना हो गया यार, strategy से it's more important than strategy is doing things on a daily basis. I think that is what matters. Apple Guider, you would be shocked to know how our examiner bodies love this truck driver, you know, AIDS positive truck driver phrase that comes up. So I picked it up from there, and our patient is ending up with development of seizures, and I am getting answer as cryptococcal neoformans, which is not the correct answer. Is there any mention of any meningitis in this particular case, guys? Is there any nuchal rigidity described in this particular case? Absolutely not. I mean, for meningitis as a diagnosis, you need to have fever, you need to have evidence of raised ICP in the form of headache, vomiting in this particular case. There has to be presence of nuchal rigidity in this particular case. So since none of them is given, so this is not a case of cryptococcal meningitis, and he is giving you history of seizures, he is giving you a lumbar puncture finding as well, so you have to pick it up. ये जो आप यहाँ पर देख रहे हो, in the area of the basal ganglia is where the parasite is present. It is causing infection with respect to the lenticular nucleus. It is adjacent to the thalamus. On the right hand side as well, there is a cerebral edema which is present around the initial infection which is present. I have explained. Okay, now it should be visible. Viral meningitis and brain abscess. Okay, C and D. Yes. पढ़ लो यार, viral meningitis. Meningitis is unlikely. Why? Because in this particular case there is no nuchal rigidity, and then viral meningitis should be having increased lymphocytes. Read the CSF finding of this patient. The CSF shows 5 lymphocytes per cubic millimeter. 5 lymphocytes per cubic millimeter is normal. There is no lymphocytosis, so I'm ruling out option number C in this case because there is no evidence of CSF lymphocytosis. The CSF lymphocytes are bound to be increased. They're given to be normal in this case. ब्रेन एब्सेस में हाई ग्रेड फीवर होगा, चिल्स होंगे, राइगर्स होंगे. ब्रेन एब्सेस मल्टीपल हो जाए थोड़ा सा अनलाइकली है ना, तो we'll talk about a common disease in this case. I think a lot of you have not listened to the AIDS video. उसमें मैंने ये समझाया भी हुआ है. Opportunistic infections in AIDS are always asked. If they ask you about seizures in a AIDS positive patient, you guys should have cracked this question in the first 15 seconds of reading the question itself, even if you're not able to figure it out. That AIDS positive patient में जो seizures का leading cause होता है, that is cerebral toxoplasmosis. The leading cause of meningitis is obviously cryptococcus, but seizures is cerebral toxoplasmosis. You will treat this chap with sulfadoxine pyrimethamine. You have an MRI image. Involvement is with respect to the basal ganglia where the cerebral edema component is present. CD4 count, yep, if given in a question would be less than 100. And then more importantly, yeah, ring enhancing, contrast enhancing lesions present. So contrast enhancement can be present with tuberculoma, contrast enhancement can be seen with NCC, and can be present with toxoplasmosis as well. So the correct answer for this one is option number B. And now I think most guys have been able to figure it out as well. So for future, do remember the statement that I have currently said. Okay, cool. Let's move to the next one for today. We are having this patient with neurocysticercosis. He's having recurrent GTCS episodes in the emergency room. And yeah, Utkarsh, sulfadoxine pyrimethamine, cotrimoxazole, other drugs, sulfadoxine pyrimethamine, pyrimethamine would be the first answer. ट्यूबरक्लोमा इन दिस हिस्ट्री, ट्यूबरक्लोमा अगर होता तो फिर यार ट्यूबरक्लोमा में वी वुड हैव हैड CSF lymphocytosis, वी वुड हैव दैट लो शुगर इन द CSF, प्रोटीन्स गेटिंग एलिवेटेड. इसमें तो नहीं है ना, इट्स ग्लूकोज इज नॉर्मल 0.7, any CSF sugar of 0.6 or more is perfectly normal. So yep, let's move on to the current question. We are having a neurocysticercosis with a GTCS episode in the emergency room, and he says, how would you manage this guy? Because he's having multiple episodes, we would be giving diazepam to this patient. We are waiting for the episodes to stop. No doc, in the casualty, I mean emergency room में तो wait नहीं करेंगे ना कि भाई उसके seizure stop हो जाए और तेरे को सफ़र थोड़ी ना करने देंगे. So we are gonna be using diazepam for management of this case. और albendazole नहीं देते हैं. अगर if you, its answer is not B guys, we don't give albendazole directly. If albendazole will be given, it will kill the parasite, it will worsen the cerebral edema, and it will cause deterioration of this patient. All he's asking is that what are you gonna do as initial management of anybody who's having recurrent episodes of seizures? We have to give diazepam followed by a phenytoin infusion. The phenytoin infusion will reduce the chances of him having another episode of GTCS, because recurrent GTCS can cause hyperthermia. Recurrent seizures can be contributing to hyperthermia. Recurrent seizures can be contributing to possibility of aspiration. They can cause lactic acidosis. So I want to avoid all those complications. He's simply asking you, how do you handle recurrent GTCS episodes, which he has not written the word status epilepticus. That's okay. I mean, the patient's total duration of episode may not have been measured. I've explained GCSE's definition is a standard, we always talk about generalized convulsive status epilepticus, where a person is having seizures which are lasting for a duration more than 5 minutes. Now, no relative, कोई घड़ी लेके तो खड़ा होगा नहीं ना कि वो रिलेटिव जो है वो घड़ी लेके बैठा है और वो कह रहा है भी मैंने मेजर किया 5 मिनट से ज़्यादा है, तो वो तो ये बोलेंगे कि डॉक्टर साहब यहाँ पे ना बार बार जो होता है पेशेंट को दौरा पड़ रहा है. सो व्हाट वी विल डू इज वी विल बी गिविंग डाइजेपम. Why not see, Dr. Saab, it will be very messy and unhygienic. I think giving rectal diazepam to somebody who's having a convulsion with that violent shaking of the body and turning the patient to one side is gonna be messy, unhygienic. You can put a IV line, no? So IV line के साथ करना है ना. So that is the one. The correct answer for this one is option number A, and IV diazepam followed by phenytoin. मैं नीट पीजी का पेपर सेट नहीं करूंगा सर, लेकिन पुराने पेपर्स देखोगे तो उसमें क्वेश्चंस में इसी टाइप का ट्विस्ट रहता है. तो बोथ नीट पीजी एंड एफएमजी वाला जो क्वेश्चन पेपर है आप उसको एनालाइज करके देखो. राइट, इफ़ यू आर सेटिंग फॉर द फर्स्ट टाइम तो आपको मेरी बातें मजाक लगेंगी, बट इफ़ यू टॉक टू दोज पीपल हु हैव ऑलरेडी एंड्योर्ड द पेपर वंस, तो फिर उन्हें दे गेट अ मच मोर I would say, orientation of the fact that I'm saying. चलो जी, होम बेस्ड मैनेजमेंट तो नहीं है. सो आई yes, 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 Daisy, would we give it in an acute condition? Yes, we'll give dexamethasone to these patients, but imaging to abhi matlab, we if we document cerebral edema, we can give hydrocortisone or dexamethasone to the patient. चलो, आंसर टू दिस वन इज ऑप्शन नंबर ए. मेरा मैसेज आपको है, आज जीसीएससी का मैनेजमेंट, स्टेटस एपिलेप्टिकस का मैनेजमेंट पढ़ लेना. वो जीटीसीएस में भी अगर स्टेटस एपिलेप्टिकस देगा, मैं आई एम एड्रेसिंग स्पेसिफिकली एफएमजी स्टूडेंट्स. लास्ट टाइम के जून के पेपर में क्वेश्चन था, जीटीसीएस के पेशेंट को जीसीएससी हो रहा था, उसने जीसीएससी का ट्रीटमेंट पूछा था, लोग जीटीसीएस मार्क करके आ रहे थे. दैट इज वैल्पोराइड. भाई वैल्पोराइड इज ड्रग दैट इज यूजफुल फॉर जीटीसीएस, बट ही आस्क्स जीटीसीएस वाले को स्टेटस एपिलेप्टिकस हो गया, क्या करोगे? So it's gonna be diazepam, then it's gonna be phenytoin, then it's gonna be IV valproate for the patient. So answer is option number A. Let's move on to the next one. Um, Dr. DKH, no, there was one in Aurangabad. Not. I think it could be only once in a year only. So maybe next year I can see you there. Okay. नहीं नहीं नहीं, मैं कोई पेपर नहीं सेट करता यार. मेरे को तो मतलब आदत हो गई है, पर स्टूडेंट्स गो थ्रू दैट टॉर्चर एवरी सेशन, सो दे कम टू मी विद द क्वेश्चंस. तो मुझे समझ में आ गया कि भाई वो क्या पूछ रहा है, उसकी साइकोलॉजी क्या है, राइट? ओके जी. So we are sorting with the next one, sudden onset. This is a easy one. Sudden onset, face weakness, arm weakness, and leg weakness in a 60-year-old patient. Is a known patient of valvular atrial fibrillation on valvular atrial fibrillation on coumarin. That would be warfarin-based molecule, and he's probably having warfarin toxicity, which is contributing to a CNS bleed. And this CNS bleed is the reason why the manifestations are those of face, arm, and a leg weakness. Okay, so this, I think most guys have got it right, because there's a face weakness, arm weakness, and a leg weakness, which means that the bleeding is occurring in the internal capsule of the patient. The correct answer to this one is option number B. I got A as an answer. That is the commonest site of CNS bleeding, but that does not explain the manifestations. If you go through the main, or even if you go through the rapid revision part, no, I have shown I've drawn like this internal capsule, which would be bisecting two structures. Like on the lateral side of this is gonna be the putamen and the globus pallidus, and the medial side of it would be the caudate nucleus. And bisecting the two like this, that I've shown in color blue, is gonna be the internal capsule. So the internal capsule, the posterior limb, is going to be having fibers which are going to be controlling the face and the arms and the legs of this patient. And therefore, the putamen is the site from where the bleed will present. No? So putamen involvement will mainly cause involuntary movements. No? If putamen is involved, then putamen will cause involuntary movements. Putamen involvement contributes to acidosis in a patient. So basal ganglia manifestations will be there, no? But if it's a pure motor stroke, that the blood supply, that is lenticulostriate artery की penetrating branches होती है ना? Like if I draw like this, if I say this is lenticulostriate, it will be sending branches like these. So those penetrating branches are the ones which are getting affected, and because of that, the manifestation will occur. Yes, Soumya, you're right. The dense stroke, that's a pure motor. I mean, the key word which somebody mentioned right in the beginning, and it's been quite frequently asked in the exam, is pure motor paralysis or pure motor stroke, is what I've explained. I mean, pure motor stroke, pure sensory manifestations of Degeneracy syndrome are seen in subcortical stroke, where the internal capsule would get affected. So, yep, I hope it was visible now. While there's a face weakness and arm weakness and leg weakness. Cerebral embolism in this case can be a reason. Yep, can be a reason. I mean, we can't predict, because he's on an anticoagulant, the first risk that I'll consider would be a possibility of a bleeding in this particular case. Shreyansh, I took a class in actually in January, and just before actually the exam had been postponed. So currently we are very near, and I think that it would not be a very optimal or a good idea to do it. Ankit, motor cortex 4 is not the one that is being affected. How will area 4 bleed show? Area bleed will only cause face weakness and arm weakness, but there would be no leg weakness. Area 4 bleed alone, Dr. Daisy put up that question. Area 4 bleed alone is going to contribute to only face weakness, arm weakness, and then there's going to be aphasia, right? I mean, because the middle cerebral artery is getting affected, so there could be Broca's aphasia, motor aphasia, global aphasia developing in the chap. So A wale feature na aphasia, apraxia, agnosia, that kind of things, they are coming cortical stroke. If it's a pure motor stroke, it's a subcortical stroke. Okay, ji. So we look to a very bread and butter kind of a question. A villager comes with altered sensorium for last 2 days. Signs of meningeal irritation are absent. So there's no meningitis described, but there is evidence of hemolysis. I mean, how is he telling me evidence of hemolysis? The hemoglobin is less, the LDH of the chap is elevated, unconjugated bilirubin is getting elevated. Everything is pointing towards RBC destruction. Plus, I'm picking up that banana-shaped gametocyte which somebody commented. So we know that we're dealing with a case of falciparum malaria, and a chap with falciparum malaria, I will have to give artesunate for this case. So the clinical diagnosis in this particular case is cerebral malaria. So you can see that, some of them are gonna be easily solvable and some of them are gonna be little on the trickier side. So for every one right possibility, one going wrong is there. That इसको minimize करना है कि law of odds यही होता है ना कि यार एक सही है गलत है एक सही है तो score crash कर जाता है. So it is like our brain is gonna be like that only. Like we get one right, we are elated, then the next one goes wrong, and then the score tends to go down. So वो आपने minimize करना. It should be like, for every 5 rights that you do, one should go wrong. If that's the percentage, then you move on to, great GT scores. Okay, ji. So let's work it out, guys. We are having this lady who's presenting with the worst headache of her life, and she's having nuchal rigidity as well. The diagnosis would be subarachnoid hemorrhage, and her GCS is on the lower side. The CT head is planned. Which of the following findings on a CT head would match? No Philadelphia. There is no twist in this one. This was malaria, right? So malaria बाकी बनता ही नहीं ना. Acyclovir जो होगा that would be given in herpes simplex encephalitis. Ceftriaxone जो होता है वो बैक्टीरिया में देते हैं, और एम्फोटेरेसिन बी जो होता है that would be given for patient of cryptococcal meningitis. Okay, ji. So yes, guys, we are looking for answers. A subarachnoid hemorrhage. Subarachnoid hemorrhage will cause bleeding. It can cause star or death. It can cause blood accumulation in the basal cisterns, and that blood in the basal cisterns would be contributing to a hyperdensity. It cannot be A because it is written hypodensity. Hypodensity is a feature that is seen with acute ischemic stroke. So option A can be ruled out. I'm left between 3 hyperdensities in this case. So option number B is intraparenchymal. This would be seen with intracerebral hemorrhage. Intracerebral hemorrhage can occur due to warfarin toxicity. It can be seen due to trauma, drug abuse, and punctuate hyperdensities at gray matter white matter interface are seen in acute diffuse axonal injury, DAI. Ankit, you got it spot on. The answer to this one is option number D. And yes, we use a Hunt Hess scale for evaluation of these patients. Blood in the Sylvian fissure is an early manifestation, but then subsequently that blood due to gravity would move down to the basal cisterns where the star of death would come up. Treatment of choice for this guy would be angiography. I mean, if he says what is the treatment of choice for subarachnoid hemorrhage, then your answer is endovascular coiling. Even if drug is given, don't answer the drug, because the drug will not treat the bleed. It will not treat the aneurysm. If he says what is the treatment of choice for this condition, do not answer the drug. Drug will only prevent the vasospasm component. What you are gonna do in this case is put in a angiography and put in a coil in that aneurysm, and there could be sister aneurysms as well which could be bursting. And शाहिद अभी और मेहनत करो, ठीक है? तो अभी 70% 80% के बारे में नहीं सोचना है अभी. Like, in the exam and in subsequent sessions, we're gonna introduce a bit of more questions which can cause difficulty in solving as well. तो अभी overconfident नहीं होना है. Coiling is better or clipping is better? Ankit, coiling will be better because it's a interventional procedure, minimally invasive. Aneurysmal clipping is gonna involve a craniotomy, and craniotomy implies that person's hospital stay would be relatively much more longer. Conventional angiography would be superior over a DSA. Divyansh, you put up that query. Doing a conventional angiography would be superior to a conventional. I mean, conventional would anyway be better. Gautam Nagar in Delhi. Yeah. I will be coming. Yeah, absolutely. Chalo ji. Yep, I will be. Moving on to the next question. We are having a 55-year-old male. There's a joint pain which is present in this chap. The swelling is in the right big toe, so that makes the diagnosis pretty easy for us. That we are talking about first metatarsophalangeal joint involvement. It's warm, it is tender. So I'm waiting for you guys to just comment on this. This would be a possibility of query acute gout as the movement, and I just need to identify which would be the best one to evaluate this. Hi, Solution Nursing. Good to hear from you. Ankit, no. Uh, I'll be coming very soon though, Bishkek. Okay. Acute gout, right? Let's have the answers, guys. Yep, yep. It would be a turbid fluid, and turbid fluid would be having a high cell count. I'm getting a clear fluid to nahi yaar, क्योंकि it's inflammation, no? So inflammation would always contribute to fluid that would be turbid, but when you're gonna examine this turbid fluid, they would be negatively birefringent crystals in a polarized microscopy. The main point is the fluid will look like as if it is septic arthritis, but the differentiating feature would be gram stain in this case will turn out to be negative, and fever can be a presentation in both septic arthritis as well as in gout as well. So especially NEET PG guys, if you're listening to this, fever is a common presentation for both acute gout as well as patients of septic arthritis. The differentiating feature is on the synovial fluid microscopy, gram stain, and then polarized microscopy, which in this case would reveal negative birefringent crystals which are needle shaped. Okay, so we are sorted. Acute gout can have normal findings. No, doctor. No, absolutely not. It will not have normal findings. It would be turbid fluid. Cell count can be, this is normal cell count. 2000 to 6000 is described as normal. He mentions increased cell count in a patient. So the values would be going up to 10,000 or even much more higher than that. So Shimu, I think you sorted for this one. Yellow fluid, increased cell count. So it would be more of turbid fluid, doctor, as I said. I mean, it would mimic septic arthritis. Okay, so we are sorted for this one. Let's move on to the next one. 20-year-old lady with complaints of sudden onset diplopia. This that we're doing is the last one for today. Investigation choices measured as CT angiography. Best is digital subtraction angiography. Divyansh, as I mentioned, no, first answer is conventional angiography slash CT angiography. Then is CT angiography. No, I think Divyansh, you got it wrong. It is not investigational choice for subarachnoid hemorrhage is plain CT. Then is what is the next best investigation to be done? That next best investigation is CT angiography. I'll say that again, Divyansh. Go through the rapid revision part again. What I have said is first investigation for diagnosis and investigational choice for diagnosis of subarachnoid hemorrhage is a non-contra CT scan. सारे bleed का diagnosis CT scan से होता है. CT scan के बाद क्या करेंगे? That was the question. तो या तो conventional angiography करेंगे या conventional angiography नहीं है तो हम CT angiography करेंगे. So that statement is not very well worded, and I think we can be sorted for this one. Okay, geez, this is the last one for today. Pseudo gout would be involving the knee joint. There would be positive birefringence present. And let's look at, okay, sudden onset double vision in the patient with weakness in the legs and arms and difficulty in swallowing. So there is an acute onset neurological illness which is occurring, and that is causing diplopia. There is weakness in the arms, difficulty in swallowing is also there. So the gag reflex of the person is getting affected, the swallowing reflex is probably getting affected, and the patient has been vomiting for previous few days. So let's look at what you guys are thinking. बोटुलिनिज्म के लिए यार, आई मीन बोटुलिनिज्म का आउटब्रेक इज गोना बी वेरी रेयर. यू हैव टू फर्स्ट थिंक इन टर्म्स ऑफ कॉमन थिंग्स, and the common things in a person would be anybody who's having vomiting could be having electrolyte imbalance, and hypokalemia can contribute to all these manifestations that I have mentioned. No, nimodipine is a life-saving drug. That is okay, but it is not the treatment of choice. No, because it does not treat the condition. It does not treat the condition. It prevents the vasospasm. Okay. The correct answer for this particular question is not option number. This is not Guillain-Barré syndrome, because Guillain-Barré syndrome should be having a ascending symmetrical flaccid paralysis, and there is no description in this particular case for ascending symmetrical flaccid paralysis. Myasthenia gravis is being ruled out because you need a long history for that. Here, the person has been sick for only 2 days, so I cannot say myasthenia gravis. I'm left between two possibilities, botulinism and electrolyte imbalance. So we'll first think in terms of common things. And the common thing is electrolyte imbalance. Anybody with acute onset neurological manifestations like this, arms में weakness है, legs में weakness है, patient could be having dangerous hypokalemia. So the correct answer for this one would be option number D. So, Ankit, most probably it would be my. You can mail me at marwamedicine@gmail.com. So we are sorted for this one, guys. The answer is Delta, and it was really, really nice interacting with you guys in the previous couple of hours, previous hour plus more than an hour that we are having this discussion. My objective was to explain to you that even in the exam, you're gonna have a roller coaster ride. Some of them are gonna be damn easy, some of them are gonna be tricky कि solve नहीं होंगे, and some of them are gonna be कि यार ये common चीज़ थी मैंने उसको answer नहीं किया. So I've just tried to replicate the same thing as I've currently explained at the moment. Ankit says why the drug of choice in cerebral venous thrombosis is heparin. तो अंकित जो वेनस क्लॉट्स होते हैं ना, दे आर रिच इन क्लॉटिंग फैक्टर्स, और जो आर्टेरियल क्लॉट्स होते हैं ना वो फाइब्रिन रिच होते हैं. तो जो फाइब्रिन रिच क्लॉट है तो उसमें स्ट्रेप्टोकाइनेस देते हैं. और इन कॉन्ट्रास्ट जो क्लॉटिंग फैक्टर रिच क्लॉट्स होते हैं ना, जैसे वेनस क्लॉट होता है, उसके लिए हम हेपरिन को यूज़ करते हैं. तो नेचर ऑफ क्लॉट दोनों में अलग अलग होता है. तो आर्टेरियल क्लॉट्स में और वेनस क्लॉट का इलाज अलग अलग होता है. Yep. C क्यों नहीं होगा? Because botulism as such is, he's saying first differential diagnosis ना. तो सबसे पहला डिफरेंशियल डायग्नोसिस तो बोटुलिज्म नहीं होता. बोटुलिज्म वैसे भी बच्चों में होता है, या तो हनी इंटेक के साथ होता है, या हनी इंटेक के साथ में मीट के, रॉटन मीट के कंजम्पशन के बाद में होता है. उसके एपिसोड्स बहुत लिमिटेड हैं. जैसे रिसेंटली हुआ था, कपल ऑफ इंडियन गाइज हैड गॉन टू ऑस्ट्रेलिया ऑन अ हॉलीडे, और उन्होंने वहाँ पे कंगारू मीट खाया. तो कंगारू, दे हैड किल्ड द कंगारू. वो शूटिंग करते, कंगारूज आर अ पेस्ट इन ऑस्ट्रेलिया, सो दे वेंट ऑन अ शूटिंग ट्रिप एंड दे शॉट दिस कैंगरू, और उसके बाद उसकी स्किनिंग करी और लेट इवनिंग में उसका मीट कंज्यूम किया. तो probably that meat became rotten and that is when they developed botulinism. So botulinism के लिए या तो honey intake होना चाहिए या rotten meat का consumption होना चाहिए. And because of the fact that rotten meat का consumption इसमें नहीं दिया हुआ है इस question में, हनी इंटेक नहीं दिया हुआ है, तो हम बोटुलिज्म को कंसिडर नहीं करेंगे. फर्स्ट एंड फॉरमोस्ट इज इलेक्ट्रोलाइट इम्बैलेंस which can explain the neurological manifestations, and then subsequently I will test up the patient for अगर मेरा इलेक्ट्रोलाइट्स का रिपोर्ट नॉर्मल आ रहा और इलेक्ट्रोलाइट्स को रिप्लेस, लाइक सपोज अगेन पोटेशियम क्लोराइड करेक्शन in this case, and the person is still having a weakness, that is when I'll think in terms of neurological illnesses. The learning point from this question is a patient comes with leg weakness, arm weakness, so give check potassium. Potassium may be normal, तब तो diagnosis will not be electrolyte imbalance. If it is low, give a potassium correction. If after potassium correction the leg weakness will improve, the arm weakness will improve, that means it was electrolyte imbalance. If not, then it's okay man, then I'll think in terms of neurological possibilities. So my email ID, I'll type it here, I think should come. Yep, so I think it should come up very soon. So we are sorted for today's discussion, guys. Thank you so much. Try to practice as many questions as possible on a regular basis, and if you do that, then you are gonna break on to the other side. Exam इतना difficult नहीं है. Previous year topics, Morning Star, we'll do subsequent sessions also. अभी तो बहुत सारा lined up है ना. We are having a LLR lined up. So I mean, attend the each and every session of you can talk to people who have attended our sessions in the previous year, and they got very decent marks, decent ranks, both NEET PG, FMG exam. They've been able to clear, and not because the questions are coming, because we are trying to give a concept-based discussion, and that is what matters. Because facts. So facts can come from everywhere, but then how to understand those facts, how to deploy those facts is what is actually required, and that is what we want to. That's the concept that's the gist of this entire discussion. I mean, why are we keeping these sessions is just to keep your motivation levels up, keep you guided, keep on giving you a drive. That is what we are trying to do at PrepLadder. We are trying to teach you कि भाई कैसे क्वेश्चन में से फिल्टर द नॉइस करना है, कि वो जो फालतू के वर्ड्स होते हैं ना क्वेश्चन में, जो डिस्ट्रैक्शन होता है, उसको निकालना है. एंड इफ यू गो थ्रू द क्वेश्चन, देयर इज गोना बी लाइक फर्स्ट इन्वेस्टिगेशन, बेस्ट इन्वेस्टिगेशन, नेक्स्ट स्टेप टू बी डन. सारे सवाल ऐसे होते हैं, तो वो लॉजिकली आपको निकालना है, राइट. सो यप डॉक्टर सत्संगी, वी आर श्योर वुड लव टू मीट यू. एंड Offline source, QBank, doc, there's so many of videos on YouTube channel of mine. You can attend them there. You have so much of data on PrepLadder videos. No, you can just download them to your mobile and keep on listening them on a loop. तो आप उसको सुनोगे ना बार बार तो आपको अंडरस्टैंडिंग हो जाएगी. A lot of people they keep on reading theory. They don't do questions. But my suggestion would be do combination. Do questions on a daily basis, and I think you would be good to go. So double vision diplopia आ जाता ना, because even ocular muscle paralysis can set in, doctor. That is why there can be double vision occurring in the patient. Hypokalemia में there can be, I mean, possibility of even gag reflex can be lost, swallowing difficulty. Severe hypokalemia is what I'm talking about, because the common things are muscle paralysis. And yes, I think one liners are more dangerous than 2 or 3 liners, because one liner में option नहीं होता. You know, 2 या 3 लाइनर में तो फिर भी आप एनालिसिस करके निकाल सकते हो, बट व्हेन इट कम्स टू अ क्वेश्चन स्पेशली लाइक वन लाइनर, इट्स वेरी प्रिसाइज एंड इट इज़ वेरी वेरी स्पेसिफिक. सो it's like questions भी करो, retrospective learning would help you. So God bless you. Thank you so much, and you guys would do great. Yeah, Dr. Mushahid Khan, I wish you the very best for that, and I wish you a great career ahead if you want to come into teaching. Yep, I mean, that's a brilliant field. uh, okay. They did not mention symmetric or asymmetric. Yep, there's no mention of symmetry or asymmetry in this question. Exactly. क्वेश्चन रॉन्ग होने के बाद ही तो करना है, यही तो एटीट्यूड है ना. अपैथी डेवलप करनी है यार. जैसे पेशेंट आता है तो पेशेंट से आपको, you don't have to be emotionally attached, you have to be mentally connected to the problem of the patient, है ना. अगर आप पेशेंट के साथ में इमोशनल कनेक्ट बना लोगे तो आप ट्रीटमेंट नहीं कर सकते ना, बिकॉज यू वुड बी लाइक, हाय यार ये बीमार हो गया. तो यू हैव टू डेवलप नॉट अ, आई मीन यू हैव टू बी एम्पैथिक, है ना. सिंपैथी नहीं बोल रहा, एम्पैथी. सेम एम्पैथी क्वेश्चन के साथ में करनी है, कि क्वेश्चन के साथ में न्यूट्रल होकर चलना है. सॉल्व हो गया तो अच्छी बात है, खुश नहीं होना. और अगर गलत हो गया तो क्या, कोई बात नहीं यार, आगे एनालाइज करते हैं ना गलत क्या हुआ. When the question goes wrong, you have to be developing a, जिसे बोलते हैं ना, relative apathy to the fact. If you goes correct, खुश नहीं होना. जब वो गलत हो रहा है तो सैड नहीं होना, आपको न्यूट्रल रहना है, एंड कीप ऑन डूइंग इट अगेन एंड अगेन. सो उससे वो एनालिटिकल कैपेबिलिटीज आ जाती हैं. पल्मरी कैपिलरी वेज प्रेशर जो होता है ना, फिलिंग प्रेशर ऑफ द लेफ्ट साइड ऑफ द हार्ट होता है. जैसे गाड़ी में टैंक में आप पेट्रोल भरते हो, तो जिस फोर्स से टैंक प्रेशर अंदर जाता है, जिस प्रेशर से पेट्रोल अंदर जाता है, वैसे ही PCWP जो है वो ऐसे समझो कि आप लेफ्ट साइड ऑफ द हार्ट में ब्लड भेज रहे हो. तो दैट इज द प्रेशर, फिलिंग प्रेशर ऑफ द लेफ्ट टैंक ऑफ द हार्ट. एंड अगर उसका प्रेशर बढ़ जाएगा तो फिलिंग ठीक से हो नहीं पाएगी, या इसका मतलब है कि वो टैंक जो है ठीक से काम नहीं कर रहा है. Right, that motor of the left side of the heart is not, tank analogy would not be right, it's a motor. Actually heart is a motor, so the left side of the heart is overloaded, so then you would not be able to push blood into it, and this would cause congestion in the lungs. Yeah, Dr. Daisy, I'll try to do that more frequently. So thank you so much, guys. God bless you, take care, and I'll see you again. So till then, keep solving MCQs, and happy Holi to everybody. Bye bye. Next live we are starting on PrepLadder. 13th is where my session would be on medicine. Okay, Dr. Netha, my next session I'll handle both bulbar and pseudobulbar palsy, the upper motor and lower motor one. Meanwhile, you can mail me at Marwah Medicine and I'll be able to assist you. Thank you. Bye-bye.